Hello, everyone. We'll go ahead and get started. I got 1 minute after. I want to say thank you for everyone for logging in today. I am Jacob Termel, and I am the Alarm Management Thought Leader for Clinical Professional Services here at Philips Healthcare. Our team is presenting 4 webinars to assist healthcare organizations in managing patients through this global healthcare crisis. Today, we are excited for our webinar on supporting NICU families during times of separation, presented by Christine Perez. Next slide. Before I introduce Christine, I want to go through a few housekeeping items for today's webinar. First, due to the volume of participants on the webinar today, we will not have a live Q&A session at the end. However, you can enter questions for Christine to answer by clicking the Q&A icon at the bottom of your screen and entering your questions there. Christine will collect these questions and send out the questions and responses to all the attendees. Feel free to share any best practices for supporting NICU families and any additional resources you would like to share for the participants. Next, this webinar is being recorded. You will be sent a follow-up email in a few days with not only the Q&As, but also a link to the recorded presentation. Now I would like to introduce Christine Perez. Christine is the NICU thought leader for clinical professional services at Philips. She works daily with customers across the United States to improve developmental care practices in the NICU while identifying additional gaps in care to develop clinical services to improve the overall quality of care through education, research, and change management. Christine has been a nurse for 25 years, beginning in high school at a career enrichment center where she obtained her licensed practical nurse and worked 6 years in pediatrics. In 2001, she completed her RN associate's degree at the Technical Vocational Institute and began her career in the Neonatal Intensive Care Unit. She completed her bachelor's in nursing in 2010 at the Chamberlain College of Nursing. She has an extensive NICU background, working in numerous roles, including a staff nurse, travel nurse, nurse educator, charge nurse, clinical cell specialist, and now as a NICU thought leader. Travel nursing allowed Christine to work in 18 NICUs nationally in level 2, 3, and 4s, providing an extensive knowledge on evidence-based practices. She has always had a passion for family-centered developmental care, beginning with NIDCAP training in 2001, followed with certifications as an internationally certified educator of infant massage and neonatal touch massage nurse certification. Preventative care has always been her passion, leading to her enrollment at Walden University PhD program in public health doctoral program with a specialization in community and health education. The emphasis of her doctoral research is to identify non-pharmacological measures that will provide solutions for the opioid epidemic in the perinatal environment. Coinciding with her passion for research, she has been collaborating with the Philips research team of North America, researching antibiotic stewardship within the NICU. It is my pleasure to turn this webinar over to Christine.
Thank you, Jacob, and I wanted to thank everyone for joining today. Originally, when I had put this talk together, I was going to do question and answers and interactive, but we actually have 190 people registered for this webinar, so that makes me so happy that that many people are passionate as me for family-centered care. And I also want to extend gratitude for all those working in the front lines. I can't imagine what you're going through and having to separate families from their babies during the COVID pandemic. So today I have a few objectives. We're going to go over what the current NICU visitation restrictions are as a result of COVID-19, go over the current recommendations, and the main focus of today's talk is how can we support these families during times of separation, as well as the neonate and infants in NICU. So this news article stood out to me. So in Ireland, there's 19 NICUs, and the journal IE reported this article and said that half of their level 3 NICUs are only allowing 15-minute visitations. So one family member is allowed to visit in the NICU at a time, and they rotate it throughout the day, and they're only allowed 15 total minutes. One mom explained how she was doing skin-to-skin care, and within 15 minutes the baby was taken and she had to leave the NICU. So as a neonatal thought leader and doctoral studies in public health, I can't imagine the type of implications and traumatic experiences this is going to have for our NICU moms from the separation. So the previous slide we saw the open bay concept. So it's a little harder with open bays to isolate babies that have COVID. The recommendation is for ideals to have private rooms because you're able to close the door and decrease the risk of transmission of COVID-19. Family-centered care always begins from the parking lot. How the families see the NICU begins from however when they walk into the hospital. But nowadays, it even begins just by going online and seeing what the website says. So I went to numerous websites to see what are the NICU visitation restrictions and how is this information being relayed to families. So here's what some of them said. No visitors are allowed in the neonatal intensive care. One visitor in the NICU when possible. This should remain the designated visitor throughout admission. One visitor limited to a parent or guardian. Visitors cannot be rotated. Only one parent or guardian during the child's entire hospital stay. As a thought leader, that to me, because we can have preterm babies that could be in the hospital for 6 months to a year, so statements set for the entire hospital stay, how parents feel about that, and just the new NICU design recommendations that just came out in 2020 actually say, design standard 4, that all signage and art should be family-centered and should not include the word visitor. So you can see in the wording a lot of these have visitors, but then every other ones say parent or guardian, and the ideal is the bottom one, 2 caregivers are permitted in the NICU. So now I want to talk a little about the neonatal research. We're learning more and more every day about COVID-19. This is just a few examples. So there was a retrospective analysis of 9 pregnant women that were in the 3rd trimester positive for COVID-19. They checked the amniotic fluid, cord blood, neonatal nasal swabs, the first breast milk collection, and they did not find an evidence of vertical transmission. But what's important to note is 44% of those deliveries were preterm, and the study reports they had underlying health issues. Then we look at a case report of 4 newborns that were 37 weeks. What I found interesting was 2 of the 4 cases that were the ones admitted to the NICU actually had rashes. That may be something that we want to look at moving forward with COVID-19. 2 babies in the NICU, one was a length of stay 6 days and one was 7. One did require CPAP ventilation. Then we look at a large nationwide case series of COVID-19, looking at 2,143 pediatric cases. I looked specifically for less than 1 year, that was 379. I think what's important to point out in this data is you see like 29.5% had severe symptoms. I think this just highlights that the neonatal population is vulnerable. They don't have a fully developed immune system, so COVID-19 could potentially impact them with symptoms. And I think these studies show that there's higher rates of preterm delivery. Interesting, when I was reviewing a lot of the studies in literature, I saw that it was a lot of late preterms, like 36-2, 36-3. So I think a lot of these cases are late preterm. So that leads me to some systematic reviews looking at COVID-19 and pregnancy. The first one looked at 41 pregnancies of positive COVID-19 moms. Very alarming rate, 43% of their babies had fetal distress, and coinciding with what I was just saying, 41.1% of the preterm deliveries were a little less than 37 weeks and 15% less than 34. 8.7% of those were NICU admissions. The second literature review was 32 COVID-19 positive pregnancies. 22% of the newborns were asymptomatic, 6% went to the mission, and this showed a higher rate of preterm, 47%. And then coinciding with the previous research, no vertical transmission. So they recommend that 4 things for a baby's diagnosis of COVID-19. They should have a clinical symptom, an abnormal chest x-ray. There should be a diagnosis of family or primary caregiver, and close contact with the people infected. So we know that there's probably not vertical transmission, but it is possible for them to acquire the infection post-delivery, and there's been several cases of positive COVID-19 in newborns. So one of the recommendations is not to delay cord clamping. For the mothers that are sick in an ICU and are able to pump, you want to consider increasing our donor milk supply so those babies can get donor milk and the antibodies they need to fight infection. And the recommendation is to designate a separate care area for at-risk newborns. So now I'm going to go into what are all the different recommendations for COVID-19 in the neonatal space. The World Health Organization says that COVID positive moms should be able to breastfeed, but if they do, they need to wear a mask, practice hand hygiene. They also recommend SkintoSkin and rooming in. The Center for Disease Control and Prevention report vertical transmission is unlikely, so mothers should wear a mask when she breastfeeds. And if she decides to pump and not breastfeed, then that express milk should be delivered by a healthy care provider. The American College of Obstetricians developed a really nice algorithm for healthcare practitioners that you can find on their website for pregnant women with positive or suspected COVID. And they do recommend that these women are priority tested. And they said there may be the need to separate the mother and the newborn, but this should be done on a case-by-case basis and a shared decision process. The Canadian Pediatric Society recommends that any newborn that is symptomatic, healthcare providers wear an N95. If they're receiving invasive or non-invasive ventilation pressure support, they should be in a private room with negative pressure ventilation. They recommend testing the newborns 1 to 2 hours after birth, and mom should not be able to visit in the NICU until her symptoms are clear. So like I said earlier, things are changing every day, and just yesterday, the American Academy of Pediatrics released new breastfeeding guidelines. These are promoting breastfeed with COVID-19 positive mothers, and they recommend the same thing as the CDC and World Health, that the mothers should be wearing a mask when they're feeding, but they also say they should be staying 6 feet apart when they're not breastfeeding. They really highlight in their new guidelines the importance that we maintain lactation consultants for these families. And they also give guidelines. If you're providing lactation consultants through telehealth, they recommend that you have a baby doll, a breast model, or a diagram for more optimal teaching for these families. Other recommendations by the American Academy of Pediatrics is they should be in a single patient room when possible if baby is exposed. If their single patient room is not possible, they recommend all COVID-19 exposed newborns need to be in a cohort. A little bit different texting recommendations than the Canadian Pediatric Society. They recommend, AAP recommends testing at 24 hours of age, repeating at 48 hours, and then repeating every 48 to 72 hours of positive until you get 2 negatives. AAP also recommends COVID positive moms do not go into the NICU until they have had no fever for 3 days without antipyretics, and they have to test negative 2 times within 24 hours apart before they're allowed to go back into the NICU. So why is it so important to help support our NICU families? Parents of NICU experience disconnect, helplessness, anxiety, guilt, and stress. All of these stressors lead to a decrease in emotional availability, which impacts healthy bonding of baby and infant. 4 factors go into the bonding process to be a parent. This includes the availability of parental contact, quality relationship with the nursing staff, level of social support of peers, and the quality of information that they are receiving on their baby's care. What's really interesting is I was putting together this talk and I kept seeing 4 reoccurring themes to support families, and that is communication with healthcare providers and ways to communicate with their baby, measures to improve parental empowerment, ensuring education, and providing mental health support for both neonate infants and families. This is the neonatal integrative developmental care model, and you can see the mother-infant diet is in the center. Family-centered care is integral to neurodevelopment of preterm babies. Family-centered care also decreases length of stay, lower rates of rehospital admissions, increases milk production, and provides neurodevelopmental outcomes that are more positive. We should be partnering from families from the moment of admission because any NICU admit is going to alter that bonding process. I like this little quote of Winnie the Pooh. It's just like what our families feel, I'm sure. Sometimes the smallest things take up the most space in your heart. So it's really important that we find ways to foster physical or emotional closeness for our families. Psychosocial care is of just as much importance as medical and developmental care. NICU moms have increased risk for mood disorders. Moms of preterm have higher rates of postpartum depression, anxiety, helplessness, sadness, grief, and anger. Both caregivers can have symptoms of acute stress disorder, PTSD, and difficulty with coping. That is why it's so important that mental health professionals are part of your multidisciplinary NICU team. It can provide one-on-one support to families and give them tips to reduce stress. For example, they can help them with relaxation techniques such as image-guided therapy and breathing exercises. One NICU actually uses narrative writing where they found that it's really beneficial for mothers to help with their stress. And interestingly, the most thing it helped them with is behavior and appearance of their NICU patient. So that really helped in their healing process. Because our families are at increased risk for these mental health disorders and symptoms, they really need mental health services to be doing assessments to check their mental health and being able to make sure they have appropriate referrals to psychiatrists and psychologists when necessary. Some of our families, even after a year after the NICU, will still be going to trauma-informed therapy sessions. Trauma-informed care sessions decrease PTSD, anxiety, and depression. Another intervention is mindfulness interventions. They lower depression, anxiety, and improve coping. One example is one NICU provided the families with 20-minute video of what mindfulness is, and then they gave them 5 to 10-minute MP3 music to listen to, and they found a significant reduction in anxiety and improvements in coping. I really wanted to mention this intervention because it is something you can do if the families are not in the NICU and they are separated. And the mental health professionals also make sure that these families have a secure support system and give them the necessary resources within the community if they do not. One thing that's really important to have in your NICU is a family advisory council with former NICU families that can also be part of peer-to-peer groups. So peer-to-peer support group is a parent that had a previous experience in the NICU. This has really great for the parents, improves parent empowerment, and improves relationship with healthcare workers. It also benefits the peer providing support. They have increased self-confidence and self-esteem, and it also helps in their healing process in dealing with their own NICU journey and emotional healing. There was a study of 17 moms that were in a peer-to-peer support group, and they found 47% had moderate anxiety, but only 12% had moderate anxiety for the ones that were in this support group. So it really is a powerful thing. Another thing I found really interesting is some peer-to-peer support groups are also incorporating music therapy. So they'll use a mental health professional in collaboration with a certified music therapist, and they played music at the beginning, and then they did some verbal relaxation techniques and some games with music. This intervention decreased anxiety by 37%, stress by 28%, and improved restfulness by 20%. So this is a really great way that we can support our NICU families. You can also use the peers that you have in your family advisory council to help you with education that you can provide virtually to make sure it's something that they would understand. I also saw a lot of people register from Hand to Hold, so I wanted to say thank you to Hand to Hold organization. They're doing a lot of things with peer-to-peer support, and if you go on their website, they actually have some Zoom peer-to-peer groups going on right now for our NICU families, so I think that's really wonderful. So staff play an integral role in supporting families. In my NICU career, one of my favorite things is being a primary nurse, taking care of that baby from the day it was admitted till it went home. This is really helpful to parents because they can feel familiar with your voice. They feel like they know your baby. They build that trust and relationship, and it decreases their stress and anxiety. Really important to collaborate with our developmental and child life specialists to help us figure out ways that we could communicate with families that are separated. And as I mentioned earlier, the American Academy of Pediatrics even called out the importance of having lactation consultants for families that are separated and going through this. We also want to make sure our rehab department, occupational, physical, and speech therapists are still providing services with the family. So if they're going to see the baby, maybe do a conference call during the session so parents can be part of it. If not, make sure you're following up so that they know what's going on with their baby. And then music therapists, as I spoke to, and some units have family navigators. These are staff for the NICU that help families navigate resources within their community. So that's something that could be very beneficial. I am seeing everybody's questions, so I just want to let you know that I'm seeing them, and I will be responding them via email next week. So there's different types of technology that we're using right now to communicate with families. Some units are using FaceTime, and the nurses are calling the families during care times and bath times. There's also different types of commercial NICU cameras like Angel Eye and NICView. I remember when these first came out, I wasn't so sure of them, you know, the parents video all the time, but after I got used to it, I think it was the best invention ever. The parents were able to see their baby comfortable. I was able to send the parents messages just to give them that reassurance. And I think they're a really great way to stay in touch with the family, and they can communicate with their baby. Some places are using a short message service that sends text to parents, and that really helps with providing them some information. Interesting enough, one study found that 50% of the parents found the visitation restrictions impeding, but then after they implemented some type of technology, this decreased by 13%. So it does show that our families do like the technology aspect of being able to see their baby if they're not in the NICU. More than 90% of healthcare workers feel technology is an effective way to communicate with families. So another way you can do, some hospital networks have ways for families to log in. You can put information there. There's also use of telehealth you can use. I know I worked one unit where we had the robots, and so if a doctor wasn't able to come in, they could use their robot to look at the baby and assess the baby. So maybe that's something, technology you can also incorporate during this time. There's also lots of mobile apps. I just want to caution with using mobile apps. There was a really good review on mobile apps for NICU, and less than half of them met quality, usability, and credibility, and lacked the evidence. So you just want to make sure before you're recommending a specific app that you make sure that it meets all of the standards and that it's up to date with evidence base for NICU. So technology is wonderful, but we also want to make sure that we always incorporate education, because as we know, as NICU professionals, education happens on admission. So we want to find ways that if the family is not able to be in the NICU, how can we provide that education? How can we support them? So this is a vCreate platform. It's implemented in 75 units in the UK, and you can do videos, photo updates, and the information goes to families, and it's a trusted NH video messaging. So I'm going to show you a quick little video example of something that you could do to incorporate technology in education.
A guide for parents with babies in neonatal units. Taking care of yourself during COVID-19. We know this is a very difficult time. Restrictions may be in place to protect your loved one, the staff who are caring for them, and yourself, which might mean that you cannot visit them in hospital or spend as much time visiting them as you want. This, understandably, impacts your mental health. We asked clinical psychologists and other experts who are used to working with families in difficult situations for their strategies to help us cope. Tip 1. Connect with your baby in other ways. Although you may not be able to hold your baby when visiting the unit, there are other ways that you can connect. Talking, reading, or singing to your baby. Your presence and voice are powerful. Engaging in these activities can help settle your baby's heart rate and breathing, help support their brain development, and can be calming for you too. Containment holding.
So I think that's a really great example of combining technology and education, and I think it's adorable. So we all know that music therapy, just in adults in general, lowers our stress and anxiety levels. So this is a great intervention to help families during stress. But music is actually a really great early family integrated intervention used in the NICU. It has numerous benefits for newborns, including relaxation and nurturing, and significant benefits for preterm babies. For preterm babies, it actually impacts their brain development and induces brain functional connectivity that changes association with music processing. Physiologically, it lowers their heart rate, respiratory rate, improves their oxygenation. They have less apnea, brady, and desats with it, increases sleep, decreases stress. Another study actually found it lowers the rates of re-hospital admission after 1 year of discharge. Improves language development, feeding success, developmental outcomes at 5 months. And one study found that babies that received a music intervention in the NICU have decreased fear reactivity at 12 months and decrease in anger at 24 months. It also has benefits for families. It decreases, for mothers specifically, it decreases their anxiety, and it actually improves the quantity and quality of breast milk and lowers stress. Improves parent sensitivity and responsiveness to baby's cues. It also helps promote the parental identity, which is really difficult in NICU and even more difficult when they are separated. Speech and language. Preterm babies are at higher risk for speech, language, and communication problems. They have an increased risk for receptive and expressive language disorders and lower IQ. How we can help this is by improving and increasing the amount of parent, infant, and verbal interaction. So we need to encourage our families to talk, read, and sing to their babies, whether they are in the unit or virtually. It is very important to promote early infant-parent interactions for development. In 36 babies, an increase of parent talk led to higher Bayley III scores and cognitive scores at 18 months. There are 3 things that support language development in the NICU. That's responsiveness to maternal voice, identity of the infant states, and parent-infant bonding. Another thing we can do in the NICU is reading programs. Reading programs in the NICU are wonderful. If you don't have a reading program in your NICU, I highly recommend implementing this. It fosters early literacy. Example is one NICU didn't have a reading program and only 20% of their families read to the baby. But after they implemented the reading program, this increased to 80%. What I think is really great is after discharge, 90% of these families were still reading to their babies. Reading decreases parent stress, provides them with a sense of normalcy, provides them with a way to communicate, and like we said earlier, it's an intervention for that parent empowerment. It also increases their responsiveness to cues. The next thing I want to talk about is rounding. Rounding is integral to family-centered care. Families should be part of the decision-making partners. They should be receiving daily updates and getting their calls answered in a timely fashion. What are parents saying about being involved at rounds? They say they like the one-to-one update. They like that they're allowed to ask questions. They feel like they are contributing to the care of their baby, and it increases their confidence in healthcare workers. So if a parent is still able to visit, please think about incorporating them into your multidisciplinary rounds, and if not, think of virtual conferencing, and if that is not possible, make sure someone is updating them on the status every day of their baby. So I have a love for infant massage. I can't do a talk without saying something. If the parents are allowed in the NICU, and most of the NICUs are allowing at least one parent in the NICU, so they're going to have, even if they're allowed one parent in the NICU, they're missing the support system of the other parent, caregiver. So infant massage is a way that they can reduce their stress, give them parental empowerment, and improves the attachment and bonding. Really significantly is important as it decreases postpartum depression. I mean, as I said earlier, our NICU parents have moms have a higher rate of this. So there's this type of qualitative data collection called Photovoice. And what Photovoice is how you feel when you look at a picture. So before, when I would look at this picture, I thought it was the best picture because it showed to me a NICU baby that's going home with his family, and there's nothing more rewarding in the NICU than seeing your babies go home with their family. But now when I looked at this picture as I'm putting together the talk, I felt sadness because this may be the first time that this dad is ever seeing his baby. Just like in the news the other day of that mom that she was separated from her baby at delivery because she had COVID-19. She was never allowed in the NICU, and she didn't see her baby until day of life 25. And the first thing she said was, could she touch her baby? So that's very heartbreaking, and also from a public health and thought leader perspective, what kind of emotional problems is this going to create later for these families? So we can provide education remotely beginning from admission. And a great example is the Creating Opportunities for Parent Empowerment program. This is a behavioral training program for preterm families. What they do is they provide them with the audio recording a few days after admission that talks about all the different things in the NICU environment so families understand that. A few days later, they get video recording of the preterm development, and then they get another recording a few days before discharge on roles of parents, and then a week after discharge they get information on developmental milestones. And parents really have positive effect to this program, so it just shows that ideally we would love our families to be getting education in the NICU, but when they're not, this is a way that you can provide them. So we really need, like I said earlier, support maternal mental health because they have the increased risk for postpartum depression. Some of the additional ways we can support maternal mental health is through journaling, scrapbooking, art-based interventions. We really need to improve the secure attachment and increase emotional availability because that leads to more positive mother interactions. Our goal, whenever possible, is always zero separation. And I'm just showing this that we have so many different NICU moms with different needs, so we really should be individualizing care for that mom. And if the mom is not able to come to the NICU, really make sure that you're collaborating with the postpartum nurse that's caring for her or the adult ICU nurse, wherever she may be in the hospital, that she's still getting educated on her baby and you're keeping her connected. One of the most powerful interventions that we can do in the NICU, so this is for the moms that are still able to visit, is providing skin to skin. Skin to skin provides that physical closeness, and I think one of the greatest things it does is it provides that bond. Whenever I'm doing lectures or education on skin to skin, I always like to share a personal experience that I had, because it really gave me a different perspective and understanding of the power of skin to skin. So I thought I would also share it with you today. I came from a unit, luckily, that was very developmental forward. Skin to skin was practiced on everybody. And even still today, some places do skin to skin with sick ventilated patients and some NICUs don't. Hopefully in the future, we'll all be doing skin to skin for our NICU babies. So I was taking care of this mom with 32-week twins. One of them was stable, preemie, learning how to feed, but the other one had an anomaly that was incompatible with life. So I introduced myself as the nurse for the day, and I asked Mom, what time do you want a kangaroo baby A today, and what time do you want a kangaroo baby B? She started crying, and I'm like, I never had that experience when I asked someone if they want a kangaroo. And she said, well, these babies also, so you know, were 3 weeks old. She's like, I've never held baby B because she's on a ventilator. I'm not able to. And I just didn't understand it. So I went through the chain of command, and we got approval for this mom to do skin to skin. And she did skin to skin, and everyone in the unit was crying. It was an emotional moment. I came back to work the next day, and the baby had passed away. And she had written me this letter and gave me this little bear that I'll keep forever, and said that you were the baby's angel, because if it wasn't for you, I never would have known my baby. She said I'd never connected with her until I put her skin to skin. So I think sometimes sharing our own experience and stories really validate the importance of all these interventions. The other thing that's really important is maternal voice. Early vocal contact with mother in preterm is very important for brain activation and emotional processing, and helping these babies distinguish voices. It also gives parents empowerment. If they can do recordings of their voice, they know that their baby's going to hear them when they're not there. So really encourage incorporating maternal voice for those babies that are separated. We also want to support paternal or primary caregiver. So if mom's not able to visit, but the other support system is, making sure we're doing all these interventions for that. They're attending roundings, they are involved in the care, they're doing massage, they're getting supported by mental health, they're doing music therapy. So really making sure we're incorporating these fathers and primary caregivers. My favorite, skin to skin, is also good for the bonding of fathers and babies. So making sure if they are allowed in the unit that you're providing skin. And we cannot forget about the mental health of supporting siblings. So siblings, when they have an unexpected sibling in the NICU, that actually breaks their predictability of their parents. And it actually, they looked at studies, and it actually created a traumatic event for them. So they also experience some mental health from this experience. So we want to make sure that we're not forgetting about the siblings and that we're supporting them. And there's several ways that we can support siblings. So some units did story time, where they do a little story time with siblings. This is a great time to incorporate developmental and child life specialists. And then some do sibling education classes, where they have an incubator, and then they have a doll, and they simulate different things in the NICU, and you can advance the scenarios based on the child's age. That's a great way. I actually worked at a NICU where we were able to work with the foundation and get some grant money, and we were able to get books for all the siblings. So sometimes if you don't have the resource to get these things, reach out to your community, apply for grants, because it's really important that we're supporting the whole family in the NICU. Reach Out to Read has a list of books. Hands to Hold has a list of books that are developmentally appropriate 4 age. Encourage families to talk to their children about feelings. The mental health specialists and child life specialists can help with them during their play. Some NICUs have gotten really creative. If you go online and look, there's some have made hospital-specific coloring books of like superheroes. They're really great. I think this is a great time where you can leverage your community. Maybe there's a local artist in the area that would be more than happy to create sibling activity books and work with the hospital. So I think during these times, we have to all work together and not just look at the NICU level, but the bigger picture of who else can help us during this. We really also need to support infant mental health. So a big study just came out. There was 3,141 children aged 4 to 11 and 2,379 children 12 to 14. And it showed significant higher risk of these babies that were these children that were previously preterm for psych disorders in child and adolescents. It had the highest odds ratio for separation anxiety. So you can only imagine what the levels of separation anxiety are going to be in these pre-NICU babies later on in their lives. So this is going to be a very big problem if we can't find ways to support infant mental health and family mental health. What we can do in the NICU if the family is not able to visit or if only one parent is able to visit, make sure we're providing developmental supportive care. This is a perfect picture that I put in here of containment hold. I thought it was great that they also mentioned it in the little video I showed earlier. So we do so many painful procedures in the NICU, and we do only 5% typically of positive touch. So even just doing containment hold before and after care can improve development in those babies. Want to make sure that we're doing cue-based feedings, infant massage, music therapy, decreasing stimulus in the environment, light levels, noise levels, just making sure you're creating a developmentally supportive care environment if their families are not there and if families are there. And so some more benefits of massage. For preterm babies, they have higher rates of weight gain, lower length of stay, advanced social skills, and higher development at 1 year. In term babies, parents will like this. They have decreased crying time, improves their regular sleep and wake cycles, improves circulation, and lower rates of sleep disturbances. So I want to reiterate what I really think is during these times of separation that we all work together and put our resources and best practices together. So I encourage you to send me anything you'd like to send to everyone on this call, and I can send it out when I answer the questions. But look at what resources you have in the NICU, the hospital, the community, the organization, state, regional, and national. Although this talk was supporting NICU families during times of separation, as you can see, every intervention that I've mentioned can be applied to any family in the NICU. We have lots of families that are separated for different reasons. Maybe they have to go back to work. Maybe they have a lack of childcare. Maybe they have a lack of transportation. So I think that these are all best practices that we could use for any NICU family. And I hope that if one positive thing comes out of this COVID-19 pandemic is collaboration across organizations and better family-centered care in our NICUs. So I really thank you for attending. And I just want to let you know about one more upcoming webinar. My colleague, Ray McLean, the Workflow Thought Leader, will be doing a webinar on remote monitoring of isolation patients with guest speakers Sarah McCaleb and Pete Stribling. That's next week, April 28th at 3 p.m. Eastern. And thank you again for joining me today. Much appreciated.